Welcome to the Hospital Medicine Unplugged podcast.
Today we're diving into something pretty critical in acute care endocrinology, adrenal crisis.
Yeah, AC. And it's not just an endocrine consult issue, right? This is something we as hospitalists see frequently. It's an acute, life-threatening emergency.
Absolutely. And the tricky part is it often masks itself. It can look exactly like straightforward sepsis or just severe volume depletion.
That's the challenge. We're talking about adrenal crisis, AC, which stems from a really profound lack of cortisol.
It happens in patients we know have adrenal insufficiency, AI, or sometimes it's the first presentation in someone with an undiagnosed suppressed HPA axis.
And the numbers are, well, they're concerning. The incidence in patients with chronic AI is around 5 to 10 events per 100 patient years. That's quite high.
It is surprisingly high, especially when you think about how we should be able to prevent it and the mortality.
Right.
It's stark. We're looking at about 0.5 deaths per 100 patient years directly from AC.
Which translates into a huge morbidity burden, too.
Yeah.
These recurrent crises really drive up the excess mortality we see in this population. They're already fragile.
Exactly. So our goal today, our mission, if you will, is to go beyond just the basics. We want to distill the latest evidence-based guidelines, thinking about the Endocrine Society, the European Society of Endocrinology,
Right.
and really focus on those clinical pearls. How do we get to rapid recognition? What's the immediate aggressive management? And crucially, how do we prevent this, especially in the hospital, where delays can be, well, fatal?
Okay, let's start at the beginning then. To really get a handle on the crisis, we have to understand the underlying types of adrenal insufficiency. There are three main categories.
What's the essential foundation? Because the way the patient presents, the electrolytes you expect, it all depends on which hormones are missing. Primary, secondary, or tertiary knowing that helps guide your thinking when they crash.
So let's start with primary adrenal insufficiency. Addison's disease, that's probably the one people are most familiar with.
It is. Primary AI means the problem is right in the adrenal cortex itself. It's being destroyed or it's just not functioning.
Which means you lose both key hormones produced there, cortisol, the glucocorticoid.
And aldosterone, the main mineralocorticoid. Both are gone.
And while autoimmune adrenalitis is the most common cause, especially here,
Yeah, developed centuries.
we have to keep other causes in mind. Infections, for sure. TB historically, but now maybe more fungi infections.
Definitely. Also think about adrenal hemorrhage, metastatic cancer infiltrating the adrenals, patients who had both adrenals removed surgically.
Or even medications. High-dose azoles like ketoconazole or fluconazole, they can inhibit cortisol synthesis.
That's a good point. Now, clinically, primary AI often gives you some specific clues you don't see in the other types.
Like the hyperpigmentation.
Exactly. Hyperpigmentation, often in skin creases, scars, even the gums are inside the mouth, and salt craving.
The hyperpigmentation happens because there's no cortisol telling the pituitary to stop making ACTH, right? So ACTH levels are sky high.
Precisely. And ACTH shares a precursor molecule, POMC, with melanocyte-stimulating hormone. So more ACTH means more MSH signal, leading to darker skin.
And the salt craving is straightforward. No aldosterone means the kidneys just dump sodium.
Yep, aggressive sodium wasting. That leads to volume depletion and often pretty severe hyponatremia.
Okay, so that's primary. Moving up the axis, we get to secondary adrenal insufficiency, pituitary problem.
Right. Here, the issue is impaired ACTH secretion from the pituitary. So you get cortisol deficiency because there's no signal telling the adrenals to make it.
But, and this is key, aldosterone production is usually okay.
Usually preserved, yes. That's the hallmark difference. Aldosterone is mainly controlled by the renin-angiotensin system, the RAAS, not ACTH. So mineralocorticoid function is typically intact.
Which means these patients usually don't have the severe salt wasting, the profound volume loss, or the hyperkalemia that you see in primary AI.
Correct. Causes here are different too. Think structural things, pituitary tumors, maybe after effects of surgery or radiation to the pituitary area.
Or acute events like pituitary hemorrhage apoplexy.
Yes, apoplexy. And it's something we're seeing more of now is hypophysitis, inflammation of the pituitary. Especially important to consider in patients on immune checkpoint inhibitors.
Good point. We also need to think about chronic meds that can suppress the axis at the pituitary level. Chronic opioids, for instance.
High doses over a long time, definitely recognized now as a cause of secondary AI worth screening for. The main takeaway for secondary AI is isolated glucocorticoid deficiency. Mineralocorticoids are generally fine.
Okay. And the third type, tertiary or iatrogenic insufficiency.
This is the one, frankly, that hospitals probably encounter the most. It's axis failure caused by medical treatment.
So suppression of CRH from the hypothalamus, which then suppresses ACTH from the pituitary.
Exactly. And the number one cause by far is chronic use of exogenous glucocorticoids, steroids.
And that's not just oral prednisone, right? It can be high-dose inhaled steroids, topical ones, even repeated joint injections over time.
Absolutely. Any route. The longer the use and the higher the dose, the bigger the risk of suppressing the natural axis.
Clinically, tertiary sounds a lot like secondary then.
It does. Isolated glucocorticoid deficiency usually preserves aldosterone. The crisis happens when those external steroids are stopped too quickly or tapered too fast.
Or when the patient faces a major stress, big surgery, bad infection, and their suppressed axis just can't ramp up cortisol production like it needs to.
Precisely. So understanding that underlying type of AI, primary, secondary, tertiary, helps frame things. But regardless of the type, patients usually need some kind of major trigger to push them from just being insufficient into a full-blown crisis.
Let's talk about those triggers. What pushes them over the edge?
The guidelines, the literature, it's all very clear on this. Infection is number one, the most common trigger.
Bacterial, viral, fungi. Pneumonia, UTIs.
Especially gastroenteritis. Gastritis is particularly bad because it does three things at once.
Right. It causes huge physiologic stress, increases cortisol demand.
It causes volume loss through vomiting and diarrhea.
And, crucially, it prevents them from absorbing their usual oral steroid replacement pills.
It's a perfect storm, a triple threat, as you said. But it's not just infection. Any major physiological stressor can do it.
Acute illness, major trauma, surgery.
Even severe emotional stress, though that's probably less common.
Yeah.
Anything that dramatically increases the body's need for cortisol can overwhelm their limited ability to produce it or absorb it.
We also have to consider medication issues themselves.
Absolutely. Just abruptly stopping their replacement steroids or maybe not taking them consistently. That's a common scenario in patients with known AI.
And there's that classic trap, starting thyroid hormone, like diroxin, in someone who has undiagnosed adrenal insufficiency.
Yes, that increases their metabolic rate, which suddenly increases cortisol demand, unmasking the AI and potentially triggering a crisis. Need to be very careful there.
Okay, so let's shift gears to pathophysiology and clinical recognition, because as we said, this diagnosis has to be clinical first. You cannot wait for labs.
You really can't. The core concept is this incredibly rapid spiral down into vascular collapse and shock. Cortisol deficiency is just catastrophic for blood vessels.
How so? What's the main mechanism?
It's about vascular tone. Cortisol normally makes the smooth muscle in peripheral blood vessels sensitive to catecholamines, adrenaline, and noradrenaline.
So it primes the system to respond to stress hormones.
Exactly. Without cortisol, those receptors get downregulated. The vessels become refractory. They just don't constrict properly in response to catecholamines.
Meaning you can be pumping in vasopressors like norepinephrine?
And the blood pressure just won't come up effectively. It's like, as you said earlier, pushing on a rope. You need the steroid effect restored.
And there's an inflammatory component too, right?
Yes. Cortisol normally dampens down inflammation, keeps cytokine activity in check during stress. Without cortisol, that inflammatory cascade runs wild.
Which contributes to tissue damage, organ dysfunction. Sounds a lot like sepsis.
It mirrors sepsis and actually compounds it if sepsis is the trigger. You get this amplified cytokine storm. Plus, metabolically, cortisol is vital for gluconeogenesis.
Making new glucose, so without it.
You get hypoglycemia, which can be really severe, especially in kids or malnourished patients.
And then if it's primary AI, you add the aldosterone deficiency on top of all that.
Right. That means severe volume depletion from salt wasting, the profound hyponatremia we talked about, and often significant hyperkalemia. And those electrolyte swings, especially the high potassium, really increase the risk for cardiac arrhythmias.
So clinically, what's the immediate picture we need to burn into our minds, the essential triad?
Yeah, the triad you have to recognize instantly. 1, profound hypotension or shock. Think systolic under 100, or a drop of 20 or more from their baseline if you know it.
2, signs of volume depletion, tachycardia, poor perfusion, maybe dry mucous membranes.
And 3, altered mental status. Confusion, lethargy, delirium, even coma. That combination should scream adrenal crisis and prompt immediate action.
But the early symptoms can be really vague, can't they?
Oh, absolutely. Almost everyone has severe fatigue. Nausea, vomiting, often intractable vomiting, and acute abdominal pain are incredibly common.
That abdominal pain point needs emphasis. It can be severe, diffuse, maybe even with some rigidity, making people chase a surgical cause.
Exactly. It can really mimic an acute abdomen, leading to dangerous delays while people are waiting for CT scans or surgical consults. Fever is common too, especially if infection is the trigger.
Which makes it look even more like sepsis.
Precisely. Hypotension, altered mental status, maybe a fever, nausea, vomiting. It's often indistinguishable from sepsis initially.
Now, you keep saying don't wait for labs, but once they do come back, what findings support the diagnosis?
They're very helpful retrospectively or if you get them quickly. The classic electrolytes, severe hyponatremia, low sodium, and hyperkalemia, high potassium, especially if you suspect primary AI.
Hypoglycemia is another big red flag, particularly in kids.
Yes, low blood sugar. And the kidney numbers, BUN and creatinine, will likely be elevated, reflecting that pre-renal state from volume depletion.
And hematologically, anything subtle there?
Sometimes you see lymphocytosis, high lymphocytes, and maybe eosinophilia, elevated eosinophils. It's a bit non-specific, but considered classic because cortisol normally suppresses those cell lines. Its absence lets them rise.
There was an interesting point in the guidelines about prediction. Something about sodium and CRP.
Ah, yes. In patients already known to be high risk for AC, like those with established AI, the combination of a low serum sodium and an elevated C-reactive protein, the CRP, has shown pretty good sensitivity and specificity for predicting an impending crisis.
So maybe useful if you're looking at morning labs on someone admitted who seems a bit off.
Could be a potential early warning sign. But again, these are supportive. They don't replace clinical judgment or dictate when you treat. The decision to treat is clinical, based on that triad.
Which brings us squarely to emergency management. This is the critical action phase.
This is where we save lives. The absolute mandate. Suspect AC, treat AC, immediately, empirically, no delays. We're talking minutes, not hours.
So what are the first steps? Two things simultaneously, right?
Two pillars. Immediate high-dose glucocorticoid replacement and aggressive fluid resuscitation. They happen together.
Okay, glucocorticoids first. What's the go-to?
The standard is hydrocortisone. Initial dose, 100 milligrams, IV push, or IM if you can't get IV access immediately.
Why 100 milligrams? Why hydrocortisone?
It's a big supraphysiologic dose designed to rapidly saturate glucocorticoid receptors everywhere and start reversing that vascular insensitivity. And hydrocortisone has both glucocorticoid and some mineralocorticoid activity, which is helpful, especially if it's primary AI and they're lacking aldosterone. That covers both bases initially.
Got it. So 100 milligram bolus up front. Then what for ongoing coverage?
After the bolus, the goal is to give another 200 milligrams of hydrocortisone over the next 24 hours.
How best to do that?
The preferred method, especially in critical illness, is a continuous IV infusion. Maybe 200 milligrams and 500 milliliters of saline run over 24 hours, or similar math. That provides smooth, consistent high levels.
And if a continuous infusion isn't practical?
The alternative is intermittent dosing. 50 milligrams IV or IM every 6 hours. That also achieves the 200 milligram total over 24 hours.
Okay, practical scenario. High suspicion for AC, patient is crashing, maybe you haven't drawn labs yet, or maybe hydrocortisone isn't immediately available, but dexamethasone is. What do you do?
That's the tough call to compromise. Hydrocortisone is definitely preferred for that mineralocorticoid effect. But if time is absolutely critical, if you really want to preserve the ability to do diagnostic testing later without interference.
Right, because hydrocortisone messes up the cortisol assay.
Exactly, dexamethasone does not. So you can give 4 milligrams of IV dexamethasone as the initial dose. It provides potent glucocorticoid coverage.
But no mineralocorticoid effect?
None. So if you use dexamethasone, you must be extra aggressive with saline resuscitation, and you need to switch to hydrocortisone as soon as possible once the dust settles. The dexamethasone buys you time and keeps the diagnostic window open, but it's not the ideal long-term solution in the acute phase.
Okay, let's talk fluids. They're volume depleted, maybe profoundly so if it's primary AI.
Fluids are absolutely non-negotiable. Aggressive resuscitation. For adults, start with a liter, the 1,000 milliliters of 0.9% saline, normal saline, run in rapidly, like over the first hour.
And then keep going based on response.
Keep going, usually aiming for another 1 to 2 liters, maybe more, in the next several hours. So often 2 to 3 liters total in the first 12 hours is typical. You're treating shock.
And for kids, different dosing.
Yes, weight-based. Initial bolus is 20 milliliters per kilogram of normal saline. And if they're still in shock, you can repeat that, up to maybe 60 milliliters per kilogram total in the first hour. Be aggressive.
Fluid type matters here, especially with that hyponatremia risk.
Critically important. Use isotonic fluids, only 0.9% saline, is the standard. Absolutely avoid hypotonic fluids like half normal saline or D5W alone.
Because that would worsen the hyponatremia.
Exactly. It would drive water into cells, potentially causing cerebral edema. Very dangerous. If they are hypoglycemic, though,
Then you need dextrose.
then you add dextrose to the isotonic saline. So D5NS, dextrose 5% normal saline, or maybe even D10 normal saline if the hypoglycemia is severe, but always in an isotonic solution.
Okay, steroids and fluids are going. What else needs immediate attention? The underlying cause.
Yes, since infection is the most common trigger, and AC looks just like sepsis.
You have to treat for sepsis, too.
You have to assume infection is present until proven otherwise. Start empiric, broad-spectrum antibiotics immediately, right alongside the steroids and fluids. Don't wait for cultures if you suspect infection clinically. Treat both life threats.
What about vasopressors? If the blood pressure is still low despite fluids and the initial steroid bolus?
Pressors are secondary supportive measures. Only use them if hypotension persists after you've given adequate high-dose steroids and significant volume.
And if you need them, which one?
Norepinephrine is generally preferred. Primarily alpha agonist effect to increase vascular resistance. Avoid dopamine if possible. It doesn't offer advantages and might have more side effects. But really, if they're still refractory, double-check your steroid dose and your fluid volume first. The steroids need time to work on those vascular receptors.
How about the electrolytes? Hyperkalemia, hyponatremia.
The good news is the hyperkalemia, if present, often corrects itself fairly quickly with the saline resuscitation and the mineralocorticoid effect of the high-dose hydrocortisone.
So you usually don't need specific potassium-lowering therapy like insulin and glucose.
Rarely. Only if it's severe life-threatening hyperkalemia with EKG changes. For the hyponatremia, the main thing is caution during correction.
Don't correct too fast.
Right. Monitor the sodium closely. Aim for a rise of no more than 8, maybe 10 millimoles per liter in the first 24 hours to avoid osmotic demyelination syndrome. The saline and steroids usually bring it up gradually and safely.
Okay, the patient is stabilized, resuscitation is ongoing. Now we can think about diagnostic evaluation, confirming the diagnosis and figuring out the cause.
Exactly. But the golden rule remains. Definitive testing, like dynamic stimulation tests, only happens after the emergency is over and the patient is stable. Never delay life-saving treatment for testing.
But if possible, before that first steroid dose, we should try to grab some baseline labs.
If the situation allows even a minute or two, yes.
Yeah.
Absolutely critical. Draw blood for a random serum cortisol and an ACTH level.
What cortisol level is suggestive in this context?
In a critically ill patient who should have a high cortisol level due to stress, a random cortisol below 5 micrograms per deciliter is highly suspicious for AC. Even levels between 5 and 10 are concerning and warrant strong consideration.
And the ACTH level helps differentiate the type.
Correct. ACTH, corticotropin, will be super high in primary AI because there's no cortisol negative feedback. It'll be low, or maybe inappropriately normal, in secondary or tertiary AI where the pituitary isn't making ACTH properly.
So cortisol, ACTH, electrolytes, glucose, that's the minimum data set to try and get before the first hydrocortisone bolus.
That's the ideal, yes, if there's time. If not, treat first, ask questions later. Dexamethasone is the alternative if you really want to preserve testing ability but can't wait.
This naturally leads into the differential diagnosis because, as we said, AC looks like a lot of other critical illnesses.
That's often the biggest hurdle, especially in the ER or early on admission. Sepsis, septic shock, that's number one, mimic.
Yeah.
Same features. Hypotension, altered mental status, maybe fever.
Hypovolemic shock from other causes too, like GI bleed or severe dehydration.
Yep, presents very similarly.
So at the bedside, any quick clues to help distinguish AC from sepsis before labs or the steroid response?
It can be tough.
Yeah.
Sometimes patients in AC shock are paradoxically cold, maybe even hypothermic despite infection, whereas septic shock is often warm shock initially. Also, the shock in AC is characterized by that high vascular resistance that's initially refractory to fluids.
Until the steroids kick in.
Right. The really dramatic, rapid improvement in blood pressure after that 100 milligram hydrocortisone bolus is almost pathognomonic for AC. Sepsis usually responds more gradually to fluids and antibiotics.
We also need to rule out other shock types quickly.
Definitely. Things like massive PE causing obstructive shock or cardiogenic shock from a big MI.
Point-of-care ultrasound can be really helpful there.
Absolutely. A quick POC US looking at the heart checking for RV strain in PE or poor global function and cardiogenic shock can help differentiate rapidly.
And don't forget other endocrine emergencies.
Right, the must-not-miss ones. Mixed edema coma from severe hypothyroidism presents with hypothermia, bradycardia, hypotension, but usually not the electrolyte changes of AC.
Or DKA and HHS, diabetic ketoacidosis, and hyperosmolar hyperglycemic state. They cause shock and altered mental status, but the sky-high glucose and acidosis usually make the diagnosis obvious quickly.
Correct. Once the patient is stable, then you might consider imaging to find the underlying cause of the AI if it wasn't already known.
Like a pituitary MRI if you suspect secondary AI.
Yes, to look for tumors or other structural lesions, or maybe an abdominal CT if you suspect primary AI was due to adrenal hemorrhage, infection, or infiltration by cancer. But again, these are follow-up tests done only when the patient is out of the woods.
Okay, great. Let's move into the final but really crucial phase, transitioning to maintenance therapy, prevention strategies, and thinking about prognosis.
This is all about long-term survival and quality of life, preventing the next crisis.
So the patient's stable, hemodynamics are good, they're eating and drinking okay, usually after 24-48 hours of IV stress dose steroids. How do we switch back to oral?
It needs to be a gradual taper. We need to get them from that high-stress dose, 200 milligrams a day 4V, down to their normal physiologic replacement dose.
Which is usually around 15 to 25 milligrams of hydrocortisone per day.
Typically, yeah. Divided into 2 or maybe 3 doses to try and mimic the body's natural cortisol rhythm more in the morning, less in the evening.
So how do you bridge that gap?
You often start the oral taper at maybe 2 or 3 times their usual maintenance dose. For example, if their home dose is 20 milligrams a day, you might start them on 40 or 60 milligrams orally per day, divided for a day or 2.
And then taper down over the next few days as they continue to recover from whatever triggered the crisis.
Exactly. Taper relatively quickly back to their baseline dose over maybe 2 to 3 days, as long as they remain stable.
Now, for patients with primary AI, there's the issue of restarting their mineralocorticoid, the fludrocortisone.
Yes, this is a common point of confusion, but really important. For primary AI patients, you must restart their fludrocortisone once they are off the high-dose hydrocortisone.
What's considered high dose in this context?
Generally, hydrocortisone doses above 50 milligrams per day provide enough mineralocorticoid effect on their own. So while they're on the 200 milligram infusion or the 50 milligram Q6-hour dosing, they don't need fludrocortisone.
But once you taper the hydrocortisone below 50 milligrams per day,
then you need to restart the fludrocortisone, usually at their previous maintenance dose, typically 0.1 milligrams daily, range 0.05 to 0.3. If you started too early, while they're still on high-dose hydrocortisone, you risk fluid overload and hypertension.
got it. What about for patients with tertiary, the iatrogenic kind, where their own axis is suppressed? How do we monitor the taper, especially if they weren't on steroids long-term before this crisis?
That requires careful monitoring, often as an outpatient. We use morning serum cortisol levels drawn around 8 or 9 a.m. to see if their endogenous axis is starting to wake up.
What level suggests it's safe to potentially stop replacement?
Guidelines often suggest that a morning cortisol, consistently above 10 micrograms per deciliter, indicates the axis is likely recovered enough, and steroids might be safely stopped, although you still need to watch symptoms.
And if it's lower, like between 5 and 10?
That suggests partial recovery. They likely still need some physiologic replacement dose, and you need to monitor them closely and plan for retesting later. Full recovery of a suppressed axis can take a long time, months, sometimes even over a year.
Okay, let's talk prevention. This feels like a huge role for hospitalists, making sure this doesn't happen again after discharge.
Absolutely critical. It involves both system changes in the hospital and intensive patient education.
So, system-wise, stress dosing protocols.
Every hospital needs clear, easy-to-find protocols for stress dosing steroids in patients with known AI undergoing surgery or facing critical illness. The standard for major surgery, 100 milligrams IV hydrocortisone at induction.
Then 50 milligrams IV every 6 hours, or that 200 milligrams per 24-hour continuous infusion.
Right. And keep that parenteral coverage going until they are definitely stable and can reliably take their oral meds. No gaps.
The second part is patient empowerment. Education on sick day rules.
This has to be thorough and repeated. They and their families need to know, for a mild fever or illness, double or triple your usual oral glucocorticoid dose for a few days.
But the really life-saving skill is the emergency injection.
Yes. Every patient with AI needs to be trained on how to give themselves an emergency injection of hydrocortisone. They need a kit prescribed.
Usually 100 milligrams hydrocortisone syringe instructions.
Exactly. They need to know how to draw it up and inject it, either intramuscularly or subcutaneously if they experience severe stress, like major trauma, or if they start vomiting persistently and can't keep their oral pills down, or if they're told to be NPO for any reason.
And importantly, that injection isn't the final treatment, right?
Absolutely not. It's a bridge they must understand. Inject the 100 milligrams, then immediately call for help or go straight to the nearest emergency department. They need assessment, fluids, and likely ongoing parenteral steroids.
And the alert systems.
Crucial. Every patient needs to carry a steroid emergency card detailing their condition and usual doses, and wear medical alert identification, a bracelet or necklace. We, as discharging physicians, have a responsibility to make sure these things are in place. Failure to do so is setting them up for another crisis.
Let's just briefly touch on complications and prognosis, just to underscore how serious this is.
The acute complications are what kill people. Irreversible shock even with treatment, multi-organ failure, AKI, ischemic liver injury from the low perfusion, and dangerous cardiac arrhythmias from the electrolyte problems, especially hyperkalemia.
And even if they survive the acute crisis,
long-term morbidity is significant. Many patients report lingering fatigue, reduced quality of life, and having one crisis significantly increases the risk of future crises.
and recurrent crises increase long-term mortality. It's estimated AC accounts for something like 15% of deaths in people with Addison's disease.
That's right. And we know certain factors predict worse outcomes. Being older, having impaired consciousness when presenting, having other conditions like diabetes, heart disease, or cancer. It really highlights the need for prevention.
Okay, so to wrap this up, this deep dive into adrenal crisis really comes down to 3 key pillars for us as hospitalists.
Yeah. First, always maintain a high index of suspicion. See the patterns, recognize the triad, and act fast.
Second, immediate aggressive treatment is non-negotiable. That means high-dose hydrocortisone, isotonic fluids right away, and simultaneously figure out and treat the trigger, which is usually infection.
And third, robust prevention. That means hospital protocols for stress dosing, but maybe more importantly, relentless patient education on sick day rules, emergency injection, and using alert systems.
But we've covered all this, the guidelines are out there, yet the incidence of AC hasn't really dropped. It's still 5 to 10 events per 100 patient years.
That persistent high rate tells us something important. It suggests it's not just about knowing the guidelines, it's about implementing them effectively. It points towards a system-level failure, particularly in getting those life-saving steroids administered quickly enough in the acute setting.
So that leaves us with a final thought, a provocative question for you, the listener, and maybe for hospital leadership and quality improvement teams.
Given that we know system changes, not just education, are needed to cut mortality from AC, what specific practical things can we implement in our hospitals, like starting this week, to truly ensure that hydrocortisone gets from the pharmacy to the patient within minutes of suspicion?
Are we talking about things like automated EMR alerts for at-risk patients showing signs of shock? Mandatory pharmacy protocols for rapid steroid release? Nursing QI audits focused specifically on that time to steroid metric? How do we actually bridge that gap between knowing what to do and doing it fast enough every single time?